Alright, welcome to Road to 250. Today's topics are going to be Nocardia and Actinomyces. And then we're going to talk about gout and gout drugs at the end. And I have a review question for you guys. So, Nocardia versus Actinomyces. So let's talk about Actinomyces first. What can you guys tell me about it? Is it gram-positive, gram-negative?
Gram-positive?
Correct, it's gram-positive. And is it anaerobic or aerobic?
Anaerobic?
Anaerobic. It's a gram-positive bacteria that forms long branching filaments resembling fungi. Where is it found?
Soil?
So you're thinking about Nocardia.
So it's found in oral.
Yeah. It's found in your normal oral flora.
Oral flora is working.
It can be found in your female genital tract, and it also can be found in the GI flora. So, what does it cause? Actinomyces.
This is yellow sulfur granule abscesses in the jaw.
Right, so head and neck abscesses in the women. It can cause IUD infections, and also can cause PID. And it classically proceeds by after dental work or trauma to the face. And usually when you're doing a physical exam, you're going to see facial mass, which is present, and it's often yellow center, as Pete was saying, because it's the yellow sulfur granules that are formed there. And they're often draining pus. So what's the treatment for actinomyces?
Penicillin.
Correct, penicillin. And sometimes you often want to also drain it. Now, Nocardia, again, it's also gram-positive, but what's the difference between Nocardia and Actinomyces?
It is partially also acid-fast.
Correct, that's correct. And one other thing.
It's an aerobe?
Correct. It's an obligate aerobe, so it loves the lungs, and produces urease, which is a way you can also diagnose it or help find the causative agent. It's a gram-positive rod, or a gram-positive bacteria that forms branching filaments. It's found in soil. That's what Divya was trying to say earlier. So, what does Nocardia cause? So
this one can cause the neural abscesses.
It can.
Like an immunocompromised patient.
Correct. So this is going to be pneumonia in an immunocompromised patient who inhale the bacteria. And usually you're going to see radio findings of a lot of things, of masses, nodules, infiltration, profusion. So whatever you can see with pneumonia, you're going to see. And then skin infections in immunocompetent patients. And these often invade the skin during gardening or farming. When with these manifestations, you can see ulcers, cellulitis, nodules, or abscesses. So those are some of the things you can see. And it can rarely infect the CNS, and it can spread there. And what's the treatment for this one?
TMPSMX?
Yes, TMPSMX. So just the first aid, and with the picture, you can see that it's not acid-fast. Well, Nocardia is an acid-fast. The one thing that the pulmonary infections can mimic TB, but they would have a negative PPD. And then the treatment, and then you can use this NAB with sulfonamides for Nocardia and Actinomyces for penicillin. So, any questions about this? Then we can move on. So give me a second. So, gout. Gout is basically uric acid deposits in your joints, and then the uric acid will mix with sodium to make a monosodium uric acid deposits in joints. And these crystals are then phagocytosed by macrophages and neutrophils, which then trigger an inflammatory response. So you can get severe joint pain, redness, swelling, and warmth as signs and symptoms. And these are basically recurrent attacks of acute arthritis. And in acute arthritis, you're going to see severe joint pain, redness, swelling, and warmth. So when you get gout, you want to think of these things. You have hyperuricemia, and it's affecting parts of your bodies that have cool temperatures. So it's not going to affect the gut because it's warmer there. So it's going to affect more distally, and it's going to do more of your knee and your your toes. So many patients with hyperuricemia do not get gout, and that's due to their genes. And then there are some people with hyperuricemia that will also get gout, and that's because their genes are just built that way. So genes play a big factor in getting gout as much as hyperuricemia does. So most common location of gout, can you guys tell me?
First metatarsal.
Correct. So it's your first great toe or podagra, and it's your first metatarsal phalangeal joint. And then it can also be seen in your knee. So primary gout is often due to no medications or no other diseases, and most of these cases are due to the overproduction of uric acid. So the causes are unknown, but usually these gout attacks are often triggered by alcohol or your diet. And we'll talk about those things in a few minutes. And then secondary are due to diseases or medications that can either cause an underexcretion or overproduction of uric acid. And then there are many causes of that, which we will also cover today. So uric acid production, it comes from your purines, essentially. So your guanosine and adenosine basically are broken down into hypoxanthine, and then xanthine oxidase converts the hypoxanthine to uric acid. And the way you can think about this is because of the two ring structures on here. So uric acid or hypoxanthine, it comes off of these two structures, the two ring structures, and it makes uric acid. So your purine sources where you can get purines from. Can you guys tell me some?
DNA.
Okay, yes. Talk about like food, like red meat.
Oh.
Yes, oils and meats and
Beer.
beer, yeah, alcohol.
Right. So trauma and surgery can also cause it, and so these are all.
Okay.
Sorry. Go ahead.
Wheat products? Oh, there's something like wheats or something.
I've
Tumor lysis.
yes, tumor lysis syndrome. That's something different, but that's can cause hyperuricemia. Correct. So from what I've read today, it's basically I've gotten these things, and then alcohol is a completely different subtopic, which I'm going to cover in a second. But these are generic, what you're going to see. And I'll talk about, okay, so let me talk about this. Red meat, why do you get uric acid from red meat is because they have purines in the muscle tissue. So when you're eating meat, you're essentially eating muscle tissue that have these purines from the animal itself. Seafood also has a high purine load because obviously the DNA, what you're eating from the seafood. And then trauma is surgery, you're just having an excess tissue breakdown. So when you're breaking down tissues, you're also releasing purines. So all of these things are just increasing your purine load. Does that make sense?
Mm-hmm.
All right. So alcohol is a different player here, but it basically is another trigger for gout. And the metabolism, when you metabolize alcohol, it consumes ATP. And so the way you can think about it is what is A? Your adenosine. So that's why you're going to make uric acid, because this pathway. And also, there's a thing called urate transport 1, which URAT1. It's found in the renal proximal muscles, or renal proximal tubules in the surface. And basically, this is a renal uric acid transporter. And what it does is it facilitates uric acid excretion in the urine. So it pulls uric acid out of the urine to basically be reabsorbed. And then when you have alcohol, you're also producing lactic acid as an alcohol metabolism. So you're increasing your lactic acid when you're taking alcohol. And that lactic acid basically is competitive. It makes the urate 1 more active, and thus making the reabsorption of uric acid to be greater. So when you have alcohol, that's the mechanism of how it's giving you gout in certain patients, because the lactic acid is increasing, and that's making the urate 1 urate 1 is also more active with the lactic acid. So then you take up more uric acid, and that's why you get hyperuricemia.
Yeah, a broad way I guess I've thought about it is your body is working to either excrete one or the other. So alcohol when you're drinking alcohol versus the urate.
Right. Yeah. Essentially. So gout attacks are more common in males, and these are more common amongst obese patients. So classic case that you may see is an obese male who had a steak dinner with a heavy alcohol consumption. So go figure. So uric acid is excreted via kidney or the urine. So these are what's leading to your secondary causes. So any reduction in your GFR decreases the uric acid excretion. So in cases where you have renal failure or volume depletion, or you're taking diuretics, will reduce your GFR, which then decreases your uric acid excretion. But diuretics can also decrease uric acid secretion in the urine, so it's like double fold. So it's making it worse. So these are many of the common causes of gout attacks are these things. So looking at this is from your first aid. We talked about under-excretion of uric acid and overproduction. So when you're talking about under-excretion, it's potentiated by renal failure, or when you're taking certain medications like diuretics. So that's what the previous slide was. You're decreasing your GFR, and that will basically decrease your uric acid excretion. And then overproduction, obviously, you have your Leishman syndrome when you have PRPP access, and increase in your cell turnover, aka tumor lysis syndrome, and where you're going to see an increase in uric acid, essentially. So let me talk about two things real fast. There's one other thing that causes hyperuricemia, and that's with your high cell turnover. Another example would be myeloproliferative disorders such as chronic myeloid leukemia, essential thrombocytosis, and polycythemia vera are associated with a high cell turnover. So you're basically increasing more metabolism of your purine nucleotides, and thus leading to more uric acid and hyperuricemia. Now, Leishman syndrome, obviously it's your defect in the purine salvage pathway. So it's an X-linked absence of the HGPRT gene, and that basically leads to an excess of uric acid production. So some of the things that you're going to see are neurologic impairments with these patients, and hypotonia and self-mutilating behavior. So classic presentation of Leishman syndrome will be a male child with motor symptoms with self-mutilation and has gout. So here's your purine salvage pathway, and what it does is when you have hypoxanthine, it can mix with PRPP with the help of HGPRT and make IMP, which then remakes your AMP and GMP. But hypoxanthine, if you don't have this to begin with, then it's going to make uric acid because of your hypoxanthine and xanthine oxidase. So that's just the pathway. And one GERD disease is your type 1 lysosomal storage disease, or glycogen storage disease, glycogen storage disease type 1. And that is your glucose 6 phosphatase deficiency. And in that case, you're going to see severe hypoglycemia between meals, and you're going to see increase in your lactic acid levels. And what we talked about earlier with the URT1, so this one is affected with this gene. So because of your increase in your lactic acid levels, URAT or enzyme is also affected. It's more active, and that's why you also see hyperuricemia with those patients. It's because of increased lactic acid leads to less excretion in the urine of uric acid. Any questions about that? All right, so just let's talk about the symptoms real fast. As we said, joints are swollen, red, and painful. And then the classic manifestations of painful metatarsal pharyngeal joint, and that's podagra. And the stophus formation is basically because your uric acid collection comes into the connective tissue. And this is usually in your ears, your tendons, your bursa. And these are usually not painful or tender, but they usually follow gouty arthritis. And they're seen with long-standing hyperuricemia. So you can see those often in the external ear or your Achilles tendon. Your acute attacks tend to occur after a large meal with foods rich in purines, as we talked about, red meats or seafood, trauma or surgery, diuresis, or alcohol consumption. So we're going to talk about diagnosis real fast. So you're going to do arthrocentesis on these patients, and you sample the synovial fluid, and you're going to see a white blood cell counts elevated, usually 20 to 50,000. And usually the normal synovial white blood cell count is less than 200. And you're going to see the crystals under polarized light, and gout is negatively birefringent. So 2 reflections of polarized light. When it's yellow, it's parallel. So you can think of, I guess everyone says, the 2 L's with the 2 L's. And that's when it's parallel in the axis of polarization. And it's blue when it's perpendicular to the polarization axis. A way you can think about that. So, any questions about gout before we move on to the drugs? All right. So, treatment. You have an acute attack. What are you going to treat gout with? NSAIDs, glucocorticoids, or colchicine. I'm not going to really focus on these 2 today, but we'll talk about this one. And then chronic or preventative, you're going to do xanthine oxidase inhibitors, pegloticase, or probenecid. So acute gout drugs, you can do NSAIDs or glucocorticoids. And, we've kind of mentioned these and talked about these before. So what about colchicine? What does it bind and stabilize?
Microtubules.
Yep, microtubulin to inhibit the microtubulin polymerization. Now, basically, it inhibits the white blood cell migration and phagocytosis, essentially, once you inhibit it. The adverse effects are basically GI, like diarrhea, nausea, vomiting. And what are the 3 times where you can use colchicine? So 2 other times besides gout. It's pericarditis, and you can also use it in familial Mediterranean fever. You can use colchicine there as well. Okay, so we're going to talk about the chronic drugs for gout. And let's start with your xanthine oxidase inhibitors. So you have your allopurinol and febuxostat. Allopurinol is a competitive inhibitor of the xanthine oxidase. Febuxostat, from what I read, is a non-competitive inhibitor. And these can be also used to prevent tuberous lysis syndrome. All right, so both of these drugs will abruptly change your serum uric acid levels, the drugs being allopurinol and febuxostat. But when you shift from a really high to a really low value of uric acid, some of these crystals will precipitate in your joints and actually cause an acute gout attack. So you initiate either a colchicine or NSAID together with either the allopurinol or febuxostat just to avoid that gout attack, essentially. Just as extra note for you guys. And then as far as adverse effects of allopurinol, it's going to be nausea, vomiting, diarrhea, can lead to hepatotoxicity, as can give you a skin reaction, and rarely does it cause bone marrow suppression. And febuxostat, from what I've read, was a second-line agent, but patients who can't tolerate allopurinol can tolerate febuxostat, so you can give them that drug. Also, these xanthine oxidase inhibitors will interact with azathioprine and 6-MP. So both of these are normally metabolized by xanthine oxidase. So when you block xanthine oxidase, you can increase the effects of azathioprine and 6-MP, but you can also increase the toxicity of azathioprine and 6-MP. So just keep that in mind. Pegloticase is basically an IV drug that can be given to patients every 2 weeks, and it's for severe refractory gout. Basically has an enzyme that degrades uric acid. It's called recombinant porcine urease, and it attaches to this polyethanol glycol, or PEG, which prolongs its half-life, essentially. And what pegloticase does, it basically converts uric acid to allantoin, which is a more water-soluble product, and that can be excreted by the kidneys. And then probenecid, essentially, blocks the uric acid excretion in the urine and blocks the proximal tubule reabsorption of uric acid in the proximal tubule. So it also blocks secretion of penicillin in the urine, so it boosts your penicillin levels. And it's a sulfa drug, and it causes uric acid kidney stones. And one last thing that I learned today is, for just aspirin, as far as how it affects uric acid levels, if you take a high dose of aspirin greater than 2.6 grams per day, which nobody ever does, that can inhibit the secretion and reabsorption of uric acid. So it can act the same as probenecid if you take that much aspirin, but in a low dose, it basically only inhibits the secretion. So you get less uric acid excretion. So that's why aspirin is not used for pain control of gout, because you're not really helping yourself with a low dose of aspirin. So if nobody has a question, we can move on to a question. All right, so a patient of a 13-year-old boy are alarmed at the increasing frequency of their child biting his lips and fingertips. In addition, on several occasions, they have noticed what appears to be particles of orange sand in their son's diapers. They report to their pediatrician that they believe their child is delayed in acquiring motor skills such as holding up his head and sitting unaided. Clinical tests performed on the serum and urine indicate a 3-fold increase in serum uric acid and 10-fold elevation in the urinary ratio of uric acid to creatinine. These findings are suggested of which of the following disorders?
C.
Sorry, could you repeat that?
C.
B or C?
C.
B?
C.
Oh, sorry. That's coming very... Okay, yeah. Anybody else? Yeah.
Same.
Mm-hmm.
Yeah, the answer is C. Do you guys need me to go over it, or are we good?
Orange sand in the diaper.
Yeah, so
Biting his
essentially,
fingers and lips.
it's the HGPRT. It's the most severe deficiency resulting in the neurologic disability, overproduction of uric acid. And then the severe form is referred to as leishmanian, and that's the orange sand, basically, is a symptom. A was STID, B was your de novo purine nucleotide synthesis, and you can usually see psychomotor retardation, epileptic seizures, growth retardation. And D was immunodeficient characterized by defective cell-mediated response. And then I think the last one was ortic acid. Yeah, ortic aciduria is usually caused by deficiency of the de novo pathway. And it's a cartoon. Anybody have any questions? That's it for me.